I'm Dr. Chris Thompson from Brigham and Women's Hospital in Boston, Massachusetts, and I'd like to thank Drs. Nguyen, Krinsky, and Riker for the kind invitation to speak at this year's conference. I hear it's fantastic, and I'd love to come in person sometime in the future. The topic of my talk is third space techniques in endoscopic obesity management. These are my disclosures. I'm working with most of the companies involved in obesity management. However, because this is a third space talk, primarily, I really don't believe any of these conflicts are relevant. Third space endoscopy has been with us for about 20 years now, originally developed in Japan as endoscopic submucosal dissection seen on the left, and eventually evolving into other types of third space procedures, in large part due to notes where we were using tunnels to create safe exit sites to access the intra-abdominal cavity. Again, Asumiyama from Japan was really behind a lot of that kind of tunneling for exiting in notes, and that's where we have the STIR procedure on the right, the tunnel endoscopic resection. In addition to third space for tissue resection, we have third space for myotomies or POEM, peroral endoscopic myotomy. And on the left, you see a typical E-POEM kind of animation where we're tunneling in the submucosal space and then making an incision in the muscle. And on the right, we have a typical G-POEM technique. Now what we're seeing is the intersection of third space techniques with bariatric endoscopy. And these techniques can be used to augment existing EBMTs, endoscopic, bariatric, and metabolic therapies by enhancing tissue preparation to promote better healing and also adding additional mechanisms of action. Or you can create entirely new procedures addressing specific pathophysiology or altering normal physiology for novel treatment effect. And here are some endobariatric procedures where we're beginning to utilize third space techniques. And first, we use these techniques for tissue preparation to promote healing when we're performing fistula closures, in particular gastrogastric fistula, and also when we're performing TOR procedures, transoral outlet reduction for failed gastric bypasses that have dilated gastrojejunal anastomoses. We also address specific pathophysiology of these techniques when we're treating sleeve gastrectomy stenosis that's refractory to balloon dilation, and we're doing tunnel stricturotomies there. And we're also using it to alter normal physiology for unique treatment effects when we're doing beam procedures. That's bariatric endoscopic antral myotomy, and we're doing these pylorus-sparing antral myotomies to delay gastric emptying. And we'll start by discussing its role in tissue preparation because this is where it was first employed in the treatment of bariatric complications. And here you see a complicated jejuno-gastric remnant fistula. So this is just on the other side of the gastrojejunal anastomosis, these 4 holes. Very challenging case. This is one of my early fistula closures, probably way back in 2006, maybe earlier. And we're using the EndoCinch device here. And so we ablate the mucosa with APC, and then we're suturing it to close it down. We studied 95 patients. We placed an average of 2.2 sutures per patient. We had a 95% initial closure rate. However, 65% of these reopened after about 177 days in that study. So we found that fistula that were smaller than 1 centimeter in size tended to do better than more durable closure. And no fistulas over 2 centimeters remained closed. So older suturing device, but similar results to the more modern devices as well. So this is a very thorough closure here. We suture it. You were using cinches here. And then we kind of double layer close this with clips over it. And then we would test it with contrast. We put contrast in to make sure it was completely closed. And this one is, of course, one that reopened. So we knew we needed to do better. And this is where we first started to introduce third space techniques. And the video on the right, you'll see we're going to inject a submucosal cushion of fluid and then make a circumferential incision around this gastrogastric fistula. And we'll then use a double channel scope with a forceps through a snare to remove the intervening mucosa and deep tissue to do a fistulectomy to get to healthy tissue, because fistula really do form in these scarred staple lines. So that's why they're so tenacious and difficult to close. So we did a retrospective series of 41 patients. 30 had a traditional APC and suturing approach, and 11 had this newer ESD fistulectomy technique. And you see here we're doing a running suture to close this. And the results, the traditional approach got a 20% success rate at just over 10 months, and the modified ESD EFTR approach got a 56% success rate overall, which is quite good. And if you look at it based on size of fistula, small, less than a centimeter, large, greater than a centimeter, There's a 33% success rate in the traditional group for the small ones versus 60%, so about twice as good there. But for the large fistula, none of those in the traditional group were closed versus 50%. So good progress. And the next most logical step was to use these techniques in tissue preparation for transoral outlet reduction for patients that have recurrence of weight gain after gastric bypass. And again, this is a very complicated issue. You have to look for dietary noncompliance and any medical conditions like thyroid disease or iron deficiency anemia that could lead to weight gain. However, if these are normal and have been addressed, you really do have to look for anatomic issues. And what you're looking for is a dilated gastric pouch or gastrojejunal anastomosis. And this is a study we did years ago when Dr. Bahram Abadaya was a fellow in my lab, and it was retrospective. We looked at 165 patients who had gastric bypass, and 59% of whom had recurrent weight gain. And we found that a gastrojejunal anastomosis of greater than 15 was associated with weight regain. And for each 10 millimeter increase in the GJA diameter, there was an associated 8% weight gain. And you can see this demonstrated here. So the bigger the outlet, the more weight gain. And this held up in multivariable regression analysis as well. So it stood to reason that making these dilated outlets smaller would probably lead to weight loss. And this is a double-blind randomized sham-controlled trial we did with the old EndoCinch device. And this is years ago. And all patients had gastric bypass with dilated anastomoses and recurrent weight gain. It was a 2-to-1 randomization scheme. So we made the outlet smaller. We were using interrupted stitches here. And for the first 6 weeks, both groups were on liquid diets, and they lost roughly the same amount of weight. But then as soon as you liberalized the diet, the sham group put their weight back on, and the treatment group kept their weight off. Unfortunately, there's only about a 3.5% total weight loss here. However, everyone who was actively regaining weight stopped regaining weight. So it was viewed as a big win and provided level 1 evidence for transoral outlet reduction. And a few years later, we had access to full thickness suturing devices. This is the Gen 1 of the OverStitch device. And these place stitches in the muscle layer, not just the submucosal space like the prior devices. So we performed a matched cohort study comparing 59 consecutive patients that had full thickness TOR versus 59 of 129 patients that prior had superficial thickness TOR with the old device. And we found significantly more weight loss placing the sutures deeper. And this was a 6% total weight loss. So it went from 3.5% to 6%. Then with Gen 2 of the suturing device, we were able to change the suture pattern. So originally we were doing all these interrupted sutures, but the newer device allowed us to do a purse string. This had several advantages of spreading out the forces, and you had an internal shock absorber with the outlet. So theoretically, a better suture for making the outlet smaller. And we did an analysis of a prospective registry that included 241 patients. 187 had the purse string procedure, and 54 had it interrupted with the same device. And you can see here, the percent total weight loss was 8.6% versus 6.4%. So clearly better with the purse string. And this held up in a regression analysis as well. And again, 8.6% total weight loss. Keep making progress. And this has good durability as well, holding up for 5 years. This is a 331 patient study that we did, showing an 8.8% total weight loss at 5 years, with 62% of subjects maintaining at least a 5% total weight loss. So this purse string is very durable. This also compares favorably to surgery. Here we have a matched cohort study looking at 62 patients, 31 consecutive surgical patients matched with 31 TOR patients. And we can see here that there's no significant difference in weight loss at 1, 3, and 5 years. However, the TOR group, the endoscopic group, had substantially fewer AEs, 6.5% versus 29%, and no SAEs compared to 19% SAE rate. So clearly, just as good from a weight loss standpoint and better from a safety standpoint. And this is what the most recent technique looks like. It's called ESD TOR, or a modified ESD TOR. And what we start with is a submucosal injection, and we then make a circumferential incision around the gastrojejunal anastomosis. And here we're using a hybrid knife, as this is very fibrotic, so you need a lot of force, hydrostatic pressure to kind of lift the mucosa here. And we're using hetastarch with methylene blue and some epinephrine. This area does like to bleed. And again, we make our circumferential incision, and we'll then ablate that inner ring of mucosa. We're using 70 watt APC forced. We do want to completely ablate that. And then we'll do a purse string suture like we've already discussed. And again, you don't want to cross your sutures here. You want this to be an open running or a continuous and running suture. You don't want to lock them because then it would be difficult to tighten it at the end. And we typically will do about 14 stitches with this one suture circumferentially. About halfway through, about 7 stitches in, we'll flip the device as you just saw there. It makes it easier. Then we'll complete it. We're not showing all the stitches for the sake of time. We then size this over a CRE balloon to about 7.5 or 8 millimeters, and we'll then put reinforcing sutures in. And this delivers very favorable weight loss results. We recently completed a series of patients using this new ESD TOR technique, and we compared this retrospectively to the older APC TOR technique. Again, both groups of patients had a purse string TOR. We're just comparing the different types of tissue preparation. We found really much more weight loss with the modified ESD compared to the APC, getting us up to 12% total weight loss, which again is considerably better than that original 3.5%. So clearly making improvement, and there is an importance to how we prepare the tissue. We'll now move on to the treatment of sleeve gastrectomy stenosis. And we'll start with a case. Here you can see there's a rather significant stenosis there on the upper GI series. This is a 22-year-old patient with a sleeve gastrectomy in 2017, having significant dysphagia due to this profound stenosis you can see on an upper endoscopy. And what we're going to do is a tunneled stricturotomy. And so first we inject some submucosal fluid, and then we'll do a mucosotomy and tunnel to that level of stenosis. And you'll see here it's very fibrotic because this person obviously has had surgery, and we're near a staple line, so those will certainly engender some fibrosis. But they also had 3 ineffective pneumatic balloon dilations, which is fairly common for these patients. So even after just making the tunnel, you see improvement in that stenosis. However, we then go on to actually do a partial myotomy and try to release that further. And this patient ended up doing quite well with durable results, no further treatments needed. You can see before and after there on the endoscopy and the upper GI, there's improvement as well. So we then embarked on a study. We did a retrospective review of 13 of our consecutive patients. The primary endpoint was clinical success, defined by symptom improvement on the GCSI, resumption of oral intake, no further interventions. Also followed their weight. Now, most of these patients had helical stenoses, so they were twisted. It was complex stenoses. And again, the majority had failed prior treatment as well. So the clinical success was 77% with no SAEs. You can see the improvement in GCSI from 2.06 to 0.39, and only 23% of these patients ended up requiring surgical revision. And most recently, we started applying these techniques to primary bariatric therapies, and in particular trying to alter normal physiology to get a desired treatment effect, which is typically slowing gastric emptying. To better understand the underlying premise, we must first briefly review gastric physiology. So the basic stages of digestion include fundal accommodation, okay, and storage of food. Then we turn that food into chyme via mixing, churning, and breakdown, which tends to happen in the body of the stomach. And finally, there's emptying, which is largely accomplished by the antral pump. Gastric interventions used to treat obesity are a subclass of EBMT, and they typically work by interfering with digestion. The original USGI pose procedure specifically targeted fundal accommodation. All the plications were placed in the fundus in an effort to prevent it from being able to relax to accept a meal. Intragastric balloons and ESG have been thought to really work by interrupting that second phase. We're affecting the grinding, mixing, and breakdown of food. And the transpyloric shuttle actually was the one that focused on gastric emptying primarily via the antral pump mechanism. Before we proceed, we must briefly talk about ESG, or endoscopic sleeve gastroplasty. And we really first developed this technique in 2008 when we did the first in human studies, and it was myself at the Brigham working together with Phil Schauer and Stacy Brethauer at the Cleveland Clinic. And we were trying to replicate a gastric imbrication procedure that was done surgically. And the pattern we came up with was placing a stitch on the anterior surface of the stomach, the greater curvature, and the posterior, creating a triangle, moving proximally, and then repeating that anterior, greater curve, posterior. And the effect would be to fold the stomach in on itself, reducing its width and also shortening its length. So this was the same pattern we used in the very first ESGs in humans, which we performed in 2012, myself together with Rob Hawes, who helped develop the device. We did these in India, and then we extended this for a total of 126 patients in India, Panama, and the Dominican Republic. And we found a good improvement in BMI from 36.2 down to 29.8. And we also had about a 19.5% total weight loss. The procedure then evolved and developed for better or for worse, and finally we had the MERIT study. And by then the pattern had changed substantially into a combination of U stitches and reinforcing running sutures. And this was a randomized trial. There was no sham arm, no blinded arm. And it compared ESG to control. And we found a 13.6% total weight loss in responders. So overall, it was about 11% total weight loss. However, the response rate was good, defined as a 25% excess weight loss at 1 year, and there's a 77% responder rate there. So this was enough to get FDA de novo marketing authorization, and we were off to the races. ESG is certainly safe and effective as the studies have borne out. However, there are significant limitations. There's no standardization, so for every doctor that performs this is a different pattern, which is not great for reproducibility. There's questions about suture loss and durability, and is one pattern better than another? Long procedure times. Early cases can go over 2 hours in some cases, and then when you get really good at it, you're still maybe taking an hour. There's a long learning curve, proposed 50 proctored cases. There's too few people properly trained to do this. It's expensive with some, in some settings it costs $6,000 for the equipment, and there's limited insurance coverage. So clearly, lots of room for improvement. In an effort to address some of these shortcomings, we proposed a novel procedure that affects several aspects of gastric motility. And we're hoping this would improve durability and deliver greater weight loss. And we called this the GEM procedure, or gastroplasty with endoscopic myotomy. And here we introduce third space. So we create a long tunnel extending from the level of the incisura all the way to the pyloric ring, and then a myotomy, the entire length of the antrum, sparing the pyloric ring. So pylorus sparing antrum myotomy, the opposite of a G-pone. We then do a running suture or a belt separating the antrum from the body to protect the mucosotomy and hopefully further slow gastric emptying. And finally, we do an abbreviated ESG, again, to affect that second phase of gastric digestion and maybe even pull down the fundus a bit, affecting the first phase. And in 2022, we published the results of our first 6 patients. And you can see here we had 6-month follow-up, and that was a 19.5% total weight loss. 100% of patients achieved at least a 10% total weight loss, so this is quite remarkable. And you can see here the gastric emptying breath test, half-life went from 90 minutes to 204 minutes, confirming a significant delay in emptying. And the GCSI scores were quite surprising. There was no worsening or really any nausea, vomiting, bloating. It was only the postprandial fullness and early satiety subscale that changed, and that was favorable. And this is what the procedure looks like. We'll start just proximal to the level of the incisura along the greater curvature. We perform a submucosal injection and then a mucosotomy. And we'll then begin our tunnel all the way to the pyloric ring. And we use a mixture of methylene blue and hetastarch. We do not have epinephrine in the fluid because we want to preserve that mucosal flap to the best of our ability. We also try to avoid taking down any blood vessels. Now, we are along the greater curvature, so we're right above that gastrocolic ligament. You can see here the pylorus is intact, and that does afford some protections, even against, in some cases, capnoperitoneum, but you are prone to getting omental hematomas and pneumo-omentum. We do our myotomy from distal to proximal.
An international survey study
and,
in 2020.
Oftentimes you keep the scope still and kind of just pull the knife back to you. But it's a challenging area for myotomy because there is scope looping that occurs, but this seems to be the fastest way. And more recently we've been making much wider tunnels and doing double or even triple myotomies in there. And this is early on where we're doing some full thickness myotomies. And you see the omentum or really the gastrocolic ligament right below us. Then we sutured that closed with a running suture. And you do a corner stitch and then about 6 stitches running, an open running pattern, then another corner stitch. And then here what we're doing is that belt suture, the running suture, which generally somewhere between 7 and 9 stitches in this suture. When what we're doing here is creating something called a neopylorus. So we're hoping to really tighten this down well and again take any tension off of that mucosotomy closure. And then we do an abbreviated ESG, typically with 2 U sutures and a few running or a few interrupted reinforcing. Then afterwards, you can see here we're using a vision scope, which senses mucosal oxygenation. You can see even though we're not using epinephrine, you do have some devascularization of that mucosal flap, and there's a nice tight sleeve above. And more recently, we've just been doing the pylorus sparing antral myotomy, and we call this the beam procedure, bariatric endoscopic antral myotomy. And we close the mucosotomy with clips, so no suturing needed at all. The first few patients did quite well, right off to the races here, getting above a 16% total weight loss. We're many more patients into it now, though, and it looks like in about 12 months we're settling out still about a little better than 12% total weight loss, which is slightly better than the weight loss you saw in the MERIT study, as I mentioned before. And you can see here the GCSI scores. There's really no nausea, vomiting, or other deleterious symptoms. There's definitely an improvement, if you will, in postprandial satiety and fullness. And the emptying here again is it's more delayed following the procedure as expected. And certainly, depending on your skill set and your training, these procedures could be challenging. However, technology is on the way to help with that. And this is a robot that we have in our lab that is going to be in clinical trials very soon for ESD of colonic lesions. However, we're also developing an ESG procedure that can be done with this. And it also is capable of doing a tunnel myotomy. So this might be something where we can do a faster, more efficient GEM procedure, or even potentially do some anastomoses. So stay tuned. In conclusion, third space techniques are making their way into bariatric endoscopy. These techniques appear to offer improved durability, greater weight loss, less variability, and a potential lower cost in some settings, such as the beam procedure. Training and certification processes are the next hurdles to broader adoption of these techniques. Thank you very much for your attention.